Welcome to a new episode of the Oncology Spotlight podcast. Today, we're honoured to host Professor Keith Kerr, a consultant pathologist at Aberdeen Royal Infirmary and an honorary professor at the University of Aberdeen. With over 35 years of experience in thoracic pathology, Professor Kerr is a leading expert in non-small cell lung cancer, specialising in predictive and diagnostic biomarkers, immunotherapy, and personalised medicine. He has made extensive contributions to lung cancer guidelines and serves on several prestigious committees, including the IASLC Pathology Committee and the ESMO Faculty for Lung Cancer. Thank you very much for joining us today, Professor Kerr. To begin, could you give us a brief introduction of yourself and your background?
Sure. Hello there, and nice to be participating in this. I'm a consultant pathologist, a histopathologist by training. I've been a consultant up here in Aberdeen for 35 years. I'm also, I have an honorary chair in pulmonary pathology with the University of Aberdeen. So I have a kind of split job between academic work and NHS diagnostic work, although the latter definitely is by far the greater part of my working existence. I've been interested in thoracic pathology forever, and yeah, that's what I do on a day-to-day basis.
Very good. And can you share your journey and what led you to become a pathologist?
Well, I went to medical school in Edinburgh, and in Edinburgh they had a program which is common to many medical schools in the UK at least, whereby selected students had the opportunity to take a year out from their medical studies, about halfway through medical school roughly, to do some research, to do a research project and do a little more academic study in a particular subject. And at the time, the most popular department to do that extra year was the pathology department in Edinburgh. And I got the chance. In fact, the professor of pathology invited me to his office, and I was terrified because I wondered what I'd done wrong. But it was to try and kind of twist my arm to apply to do this extra year in pathology, which I did, and I've never regretted it, I would have to say. So I did this research project, and I did like pathology already, so that was part of the reason for being interested in it. In my later years in medical school, I actually thought I wanted to be a surgeon. And one of the ways into surgical training in Edinburgh in those days, long time ago, was to do a year in pathology before you started your surgical training as a basis of learning pathology, anatomy, and it also gave you some time to study. But by the time I took up that post, which I had arranged, I realized that probably surgery was not for me for a whole load of reasons that we shall not go into. So I found myself sitting in pathology doing this very early training job, kind of wondering what I was going to do with myself. And again, the same professor invited me up to his office and said, I think you should become a pathologist.
Very good.
So, I was not averse to the idea. So that was it, kind of, really.
Fantastic.
Okay. Excellent. And, you know, you obviously do an awful lot of work in thoracic oncology. What led you to specialize in that space?
Well, believe it or not, the research project that I chose in that intercalated year at medical school was one of about a dozen that the students who went into pathology were offered. And the one I chose was in lung cancer. And the guy I worked with, a pathologist called David Lamb, who was a very well-known and respected lung pathologist in the UK, now sadly passed away. David was a great guy, and I found him really very inspirational. And that's how I kind of got into lung pathology, and with a particular interest in lung cancer. So I've been very boring. I've kind of stuck with one thing right from the start.
Very good. Excellent. Very interesting.
And can you explain what reflex testing is and how it applied in the context of NSCLC, non-small cell lung cancer?
So reflex testing is a concept where when an appropriate diagnosis of certain types of lung cancer is made by the pathologist then immediately will order the required molecular and other biomarker tests for that case, because the pathologist should know that the oncologist is going to require that information so that the patient can be treated properly. Mm-hmm. So the concept here is it is the pathologist who initiates the testing on the basis of the diagnosis that is made. So it can be done right there and then as soon as the pathologist makes the appropriate diagnosis. The alternative, what you might call bespoke testing, is where the pathologist makes the diagnosis, it goes back to the oncologist, there may be a discussion in the multidisciplinary team, and then the team decides, okay, we want biomarker testing, so the pathologist has to go away from the MDT, back to the pathology department, and order the tests several days to possibly a week or so later. Oh. Reflex testing means the testing is underway much more quickly. And I think it also means that probably patients won't get missed. You know, for one reason or another, a patient might not get tested, whereas with reflex testing, everyone with the appropriate diagnosis gets tested. The downside, if there is a downside to reflex testing, is that, sure, some patients will have tests that are not actually ever required. But I think that's a small cost to pay for the speed with which the vast majority of tests which are required are actually delivered.
Excellent, excellent. And what makes it crucial in the diagnosis and treatment of lung cancer today?
Well, you simply cannot treat a patient with lung cancer at almost any stage, to be honest. There are a few caveats with very early disease, but primarily we're thinking about advanced disease. But now the concept of biomarker-driven therapy is moving into earlier stages. Stage 3, we've had it for some time, and it's now very much with us for our early stage surgical patients under certain circumstances. So if we think about systemic therapy for patients, as in some kind of chemo or other drug therapy, we've moved way beyond cytotoxic chemotherapy in the lung cancer world. And we now understand that some patients whose tumors are driven by particular mutations or other genetic alterations are much better treated with a drug which targets the protein product of that genetic alteration, much better than cytotoxic chemotherapy. We also know that certain patients benefit from immunotherapy, treatments which enhance or release the immune system, which is being switched off by the tumor. It releases the immune system, which attacks the tumor. And we can identify those patients who are more likely to benefit from immunotherapy also by looking for biomarkers. So all of these treatments have revolutionized lung cancer therapy in the last 10 to 15 years. And actually, we now, and have for the last 15 years or so, selected our chemotherapy even according to the histological type of tumor that the patient has. So all this testing, and indeed the primary pathological diagnosis, is absolutely required for our oncologists to appropriately treat our patients with particularly advanced stage lung cancer.
Very good.
Excellent. Okay.
And are there specific guidelines that recommend reflex testing for lung cancer?
Oh yeah, I would say that there are plenty of different guidelines, from local area guidelines, national guidelines, and many international guidelines, which are variously adopted all around the world. Different parts of the world prefer different guidelines, and all of these guidelines recommend reflex testing, understanding that it comes with, you know, things that you have to acknowledge, that you'll probably do a few more tests than you absolutely require, which might annoy the accountants in the hospital, but it's much better for the treatment of our patients. So yeah, reflex testing definitely recommended in lung cancer guidelines.
Okay, brilliant. And, you know, we see from your profile that you've contributed to numerous guidelines for lung cancer diagnosis and management. Can you share your experiences and maybe some of the challenges in developing these guidelines?
So, you know, being part of the team that develops and draws up guidelines is a great honor and a privilege, and it's a fantastic experience. You work with lots of really good people, really talented, internationally recognized key opinion leaders, and that's never a bad thing. It really is a great learning experience, apart from anything else. So it's a great privilege to be able to do that. I think one of the things that I've noticed over the years of participating in a number of guideline productions, international guideline productions, is that there are different approaches taken by different groups, different bodies who draw these things up. At one extreme is an insistence on absolute requirement for detailed, high-level evidence to support the statements that are in the guidelines. So a strong emphasis on phase 3 trials, although obviously for certain things you will not get trial data, but there has to be published data. And that's a very complex, demanding process that requires a huge amount of literature review. And the problem with that approach, albeit that it might be regarded as the absolute best evidence, best data that is being, or best recommendations that are being given, it takes a long time. And to be honest, especially in recent years, with the rapid pace of change with treatments in lung cancer, we often find that that particular guideline, when it's published, it's out of date, because things have already moved on, because it's taken so long. At the other extreme, we see some guidelines that are changed several times per year according to the new data that are presented at the conferences. The problem there is that sometimes they're jumping the gun, and the data that are presented at the conferences are perhaps a bit early in the data cycle for a particular drug, and things don't quite pan out as expected. And so a recommendation for drug X has to be withdrawn. We've seen that. And then there's somewhere in the middle where a mixture of literature consideration and expert opinion drives the guideline without necessarily a systematic literature review. So yeah, it's a challenging job. It's sometimes a lot of work, but there's always this balance between the best evidence versus the speed with which the guideline is produced.
Okay. A question, I hear a lot about localization of guidelines. Is that a challenge? You know, like each individual trust in the UK, for example, has their own guidelines, or?
Well, you know, I think it's part of human nature that everybody wants their own guideline that's written specifically for them. How necessary that is, I'm not sure. In some countries, it will be necessary because the health systems restrict what can be done or mandate certain things are done which are possibly contrary to guidelines, and no one likes to be practicing contrary to a guideline. So you write a guideline that's, you know, sympathetic to what you should be doing, but also sympathetic to the constraints of the health system that you're working in. So we see that from time to time in certain guidelines that are written for certain countries. But I think, to be honest, most of the international guidelines are fairly reasonably reproduced when it comes to national or regional guidelines. They're pretty much the same thing, but people feel perhaps a little more comfortable when there's a national or regional label on a guideline, rather than it being some international group of foreigners that have produced the guideline. So, you know, I mean that in the nicest possible way, but, you know, people do kind of prefer homegrown things, but it's often just the same thing regurgitated.
Okay, that's very interesting.
And how is the availability of new treatment options for lung cancer patients with actionable genetic mutations impacted the importance of reflex testing?
Oh, hugely. Hugely, because as soon as a therapy is available in a particular health system or in a particular hospital, then there is an absolute requirement for that hospital to somehow deliver the appropriate biomarker testing for the drug. I mean, it would be an unacceptable situation where drugs that can greatly benefit patients are not available because testing is not available. So the pathology world has had to be very nimble, but also very reactive to the availability of new drugs. And particularly in recent years, new drugs have come along almost every other month, and we've had to suddenly provide a testing service for those drugs. So it has required us actually to be knowledgeable about what is coming and to try our best to prepare for what we fairly reasonably think is going to happen. But of course, you never quite know that the final evidence will pan out, and you never quite know if your regional authorities or regulators will give approval for certain drugs. But it's best to be ready, because it's very difficult if you're behind the curve, because you have to validate, and it takes a significant amount of time to get ready, to be able to provide accurate clinical diagnostic biomarker services. So that is sometimes a challenge, to be honest, but we do our best.
Of course. And what are the biggest challenges currently faced in the diagnosis of lung cancer?
Across the piece in the full diagnosis of lung cancer, and I'm going to include the biomarker testing in that, there are quite a few challenges. At a practical level, many of our lung cancer patients are quite sick, which means that interventions to obtain tumor tissue material from those patients can be really difficult. As a result, when we do get tumor material for diagnosis, we often don't get very much at all. And in fact, over the course of my career, the samples have got smaller and smaller, although admittedly, we have been able to biopsy more patients because of better technology. But the samples are smaller. But at the same time, we are being asked to do more and more and more with this shrinking tissue resource. So that is quite a challenge. The second big thing is just the delivery in good time of all those extra biomarker tests, which in some circumstances can take quite a long time to actually produce and deliver for clinical action. And so getting all this organized and integrated and producing the results for oncologists in good time is a challenge, and that's where reflex testing in part comes into play, but there are many other things like the technology for the testing that you use, and that technology can be very expensive, and sometimes health authorities are not quite comfortable in funding that, so that can be a bit difficult. So I think those are probably the three main challenges. We're seeing the evolution also of the utilization of blood as an alternative source of DNA in particular, on which we can do some, but not all of our biomarker testing. And that comes with its own challenges, because it's quite good in terms of specificity, but it's not quite as sensitive. But probably the best utilization of that medium is with tissue, if we can do so. But again, in many health systems, that's not funded. So yeah, there are a few challenges around.
Yeah. I'm surprised to hear that the samples are getting smaller. I would have thought that the availability of what's needed would be supplied. It would be getting better and better, but it's just reducing.
And I think across the piece, it probably is getting smaller. But as I said, that's in part at least driven by the fact that there are patients from whom we can now obtain tissue material that we couldn't obtain before.
Okay. All right.
But in obtaining that material, we have to use a technology which does not give us big chunks of tumor.
Okay.
And in fact, the very, relatively speaking, primitive approach that was the only approach when I started my training in pathology is almost never used anymore. But it would only allow access to a small proportion of tumors in a population with lung cancer. In addition, in fact, the localization of disease in patients' chest has changed over my career and has moved away from the area that was accessible by that older technology. So that also has mandated the use of technologies which de facto produce less material.
Okay, very good. And how do you
Why has it moved away? Sorry,
go on,
why has it moved away, the tumors?
Oh gosh, that's a long story. But I think primarily it's the result of changes in smoking habit. People generally smoking less. People are smoking filtered cigarettes. But also a shift in the demographic in smoking, whereby depending on which country you are in the world, more and more women have smoked or are smoking, depends where you are, past tense or present tense. And that also has an effect on the localization of the tumors, in addition to which there's some evidence that the nature of the carcinogenic environment delivered by the cigarette has changed, possibly as a result of things that the tobacco companies have done to the tobacco before they put it into the cigarette. So there's definitely been a shift from what we call central disease to peripheral disease in the chest, and that means that you have to biopsy it in a different way.
Interesting. Okay. And how do you see the training of future pathologists evolving, especially in the context of new technologies and methods?
So I think the training, to some extent, in histopathology for lung cancer will stay the same, in the sense that the diagnosis that we deliver is a morphology-based diagnostic service. So pathologists will continue to have to be trained in morphology and histopathology and cytopathology, because that is going to be needed. But the big gap, I think, that we've got in many countries, not in every country, but in many countries, is a lack of training in molecular pathology. We train our pathologists here in the UK in in traditional histo and cytopathology, surgical pathology, and morbid anatomy, but we don't formally train them in molecular pathology, not to any great extent anyway. Yet the diagnostics that we have just been discussing required for treatment, and increasingly the molecular background that we require simply to properly classify patients' tumors is increasingly requiring a lot of very detailed molecular pathology and molecular pathology techniques. So there's a gap here, and pathology training really needs to catch up in that area.
There's a lot of discussion at the moment in the media about AI and its impact on medicine. So I'm very curious to hear your thoughts on, what you guys are currently doing or using AI for, if anything, and what you see it being used for in the future.
Oh yeah, there's lots and lots of chatter and discussion and speculation about how AI might or might not help us. I'm not currently using it at the moment. I don't really think that there are AI tools that are kind of ready for routine clinical prime time, probably. But I'm sure they will come. Possibly not in my working lifetime, since that's getting very close to being over, but it will come. But the big debate, the big discussion is, how is AI going to be integrated into the workflow, the work stream for pathology in general, and let's say lung cancer in particular? And I do not have a definite answer to that question. I would like to think that what AI will do is augment what we already do. Yeah. Make us better, perhaps, at what we currently do, but also allow us to do things, especially in the arena of quantification. And, there are many, many different areas in which that might apply, looking at the localization of different cell types, the identification of cell types, the counting, the quantification of cell types, the quantification of protein expression in immunohistochemistry biomarkers, etc. It's very likely that AI will have a role to play there and make for, well, whether it's better remains to be seen, but it probably will be more consistent assessment. It may be consistently wrong, but it'll be more consistent. And take away the subjectivity and the variability of the human eye. Obviously and naturally, one's concern would be whether AI might replace the pathologist completely. And I would be gravely concerned about that. Now, of course, I'm biased, but I am concerned about that. I'm concerned that those who might fund and implement AI will be assuming that this tool will replace the human, and so cost savings to implement the AI can be saved by getting rid of or not replacing a few pathologists. That would be a grave error in my view. I think there's very little evidence to suggest that would be safe. I don't think we properly understand the capabilities of AI by itself to make accurate and consistent diagnosis across the spectrum of the things that we have to deal with. New technologies always cherry pick the easy stuff. And then the natural assumption is, oh, well, that's good, it can do the job. No, what you've just proven is it can do the easy stuff. That actually isn't much of a benefit to the pathology community. In actual fact, my view is that the easy stuff is, although sometimes people think it's a bit tedious because they don't find it very challenging, I think if you're sitting 24/7 doing hard stuff, you're much more likely to burn out and the easy stuff gives you a brief respite. So, and there are other benefits, I think, which, you know, probably we don't have time to get into just now. But AI will come, but precisely what it's going to do, I'm not so sure yet.
Okay, brilliant. Okay, thank you very much, Professor Kerr. Really appreciate your time. Thank you.
Thank you.
No problem. Thank you.